Thank you, Tony, and thank you all for your attention. I'd like to point out that between Tony Rebus and Steve Rosenberg, they pretty much taught me everything I know about cancer immunology, so thank you. And it's a privilege to be here. Thank you to John Kirkwood also for inviting me to talk. So today, I'd like to talk with you about the role of an immune response to BRAF inhibitor therapy. I list two institutions, as Tony pointed out. I spent the last 15 years at Mass General, and with great honor and pleasure of working with Keith Flaherty, David Fisher, and a number of other esteemed colleagues, and making the leap to MD Anderson to work with Mike Davies and Patrick Hu and many other esteemed colleagues who I hope to spend a long time with as well. So, with that, I'll move on to the next slide. Is the pointer? Hold on one sec. There we go. Okay. So you've seen similar slides to this before, and just to point out that melanoma remains a major cause of morbidity and mortality worldwide. However, within the past several decades, or within the past decade, key genetic mutations have been identified that contribute to the oncogenic potential. And of course, everyone knows that BRAF is one of the main driver oncogenic mutations. And when you get a mutation in BRAF, you get several deleterious effects, those being uncontrolled proliferation, resistance to apoptosis, an increase in angiogenesis, invasion and metastasis. And then what we've really focused on is its role in immune evasion. And so again, you've seen this slide many times before, basically showing that targeted therapy against this oncogenic mutation really has shown impressive results. And here's the data from the phase 3 trial showing a clear survival advantage of patients who received single agent vemurafenib over then standard of care dacarbazine. However, of course, the dirty little secret, if you will, is that the median time to progression is less than 6 months. And so, yes, there are kind of patients who benefit in the long term, but certainly the majority of patients, this effect is not long lasting. And so investigators have really proposed several ways to combat resistance to BRAF inhibitor therapy, those being further inhibition of MAP kinase pathway by adding MEK inhibition. This has been quite successful. We all know about the advances with regard to that. Also inhibiting parallel signaling pathways like PI3 kinase. Again, we've heard a lot about those. And then finally, what I'll really expand on today is the potential to combine BRAF-targeted therapy with a different modality, and especially immunotherapy. And so this slide shows some of our preclinical studies from a few years ago that demonstrated how treatment with the BRAF inhibitor can increase melanoma antigen expression in cell lines. And so, this is the slide that shows that. So basically in this slide, we show immunofluorescence for the melanoma antigen MART1. And so here on the left, this is a BRAF mutant cell line, and on the left, these are cells that are cultured in control media in the absence of a BRAF inhibitor, and you can see that there's really negligible melanoma antigen expression. However, within 48 hours, when you treat these cells with a BRAF inhibitor, you get this dramatic upregulation of MART1. And the important take-home message with this is that when you actually increase that antigen expression, you also see this is associated with an increase in reactivity to antigen-specific T cells. So we wanted to know, yes, there's an increase in antigen expression, sometimes up to 100-fold. We've actually looked at other antigens, MART1, GP100, TRP1, TRP2, and when we took those treated cell lines and cultured them with either MART or GP100 specific T cells that we got from Steve Rosenberg, we actually saw a doubling or tripling of the cytokine release as measured by interferon gamma. So I'll just walk you through this. So this is basically, we took control T cells, are T cells that are treated with a GFP or that are transduced with a GFP vector. No treatment means that these are T cells with non-BRAF inhibitor treated melanoma cell lines, and then the BRAF inhibitor shows that if you pre-treat the cell lines with the BRAF inhibitor and then incubate them with antigen-specific T cells, you get a significant increase. This was done over several dilutions and for 2 different receptors. But we know that the MAP kinase pathway is also important with regard to T cells, and so we wanted to test the effects of either BRAF inhibition or MAP kinase pathway inhibition on T cell function. And what we found is essentially that BRAF inhibition does not affect T cell function. In fact, Tony's actually elegantly shown that it can actually augment T cell function, but MEK inhibition significantly impairs proliferation and function. The top graph shows some data showing just that, and this is just T cells incubated with either one of two MEK inhibitors, this U0126 or this PD compound, or with a selective BRAF inhibitor, this PLX4720. So you see with either of the two MEK inhibitors, this is percent viability over time in days. You see that at the lowest dose, there's not a big effect. We did this at 3 different doses. At the moderate dose, there's a pretty significant effect on T cell viability, and at the highest dose, there's a really profound effect. However, if you look at the BRAF inhibitor, there's absolutely no effect. And then if you take those T cells that have been treated with either a MEK inhibitor or a BRAF inhibitor, and then culture them with melanoma cell lines, and then look at interferon gamma release, what you find, if you really kind of focus just on this MEK inhibitor, as opposed to either the control, no treatment or control plex, essentially it wipes out the interferon gamma release by the T cells. And so you significantly impair the function of those T cells on co-culture. And so based on all this preliminary in vitro data, we came up with a model where BRAF, oncogenic BRAF downregulates melanoma antigen expression, mainly through transcriptional repression of MITF. This leads to a decrease in melanoma antigen expression. And then when you block this, you can actually release that transcriptional repression, get expression of the melanoma antigens, processing and presentation, and then increased reactivity to antigen-specific T cells. And so that was our early model. And so, but that was all in vitro work, so we wanted to know if this was truly happening in patients. And so what we did, oh, and one more thing, that MEK inhibition, unlike BRAF inhibition, can actually impair T cell function. So, but again, we wanted to see, is this, sure that's in vitro, but does it happen in patients? And so at the time when we were doing these studies, Keith Flaherty had just joined Mass General, and we had a number of patients who were being enrolled onto trials with either a single agent BRAF inhibitor versus a BRAF and MEK inhibitor combinations. And what we did is we took those patients and enrolled them on a tissue acquisition protocol as well. We did biopsies of the tumors and also blood draws on day 0 pre-treatment, on day 10 to 14 on treatment, and then again at time of progression. We then analyzed the tumors not only for melanoma antigen expression, we also looked at CD8 T cell infiltrate. We looked at markers of cytotoxicity, T cell exhaustion markers, and also PD-L1. And so this is just showing the patient characteristics. We had 5 patients who were treated with BRAF inhibitor monotherapy, shown here, and then another 10 who were treated with combination BRAF and MEK inhibitors. There were a wide range of ages, and there was one complete responder, here patient number 7, and then several partial responders and some with stable disease. And so the first thing we wanted to look at is look at melanoma antigen expression. So we saw that when you treat a melanoma cell line with a BRAF inhibitor, you get an upregulation of antigens. We wanted to see if this was occurring in patients. And so we took those tumor biopsies and we looked both by RT-PCR and then also confirmed by immunohistochemistry at 4 different melanoma antigens, at MART1, GP100, TRP1, and TRP2. And we saw exactly what we had seen in vitro, where when you treat these patients with the BRAF inhibitor, you get an upregulation of melanoma antigens, sometimes up to close to 100-fold, not quite as profound as we had seen in the cell lines, but nonetheless, we saw an upregulation of melanoma antigens in these patients. We also, like I said, validated these by IHC, and so this is biopsy pre-treatment at day 0 for MART1. You can see really negligible MART1 staining. But then within 2 weeks of therapy, they actually get a pretty dramatic upregulation of these melanoma antigens. But perhaps more interesting is what we found with regard to the T cell infiltrate. And when we looked at T cell infiltrate between the pre and on treatment, what we saw is a dramatic increase in T cell infiltrate after treatment with the BRAF inhibitor. And so I show this representative sample here, where here's pre-treatment by H&E, here's pre-treatment with the CD8 stain. And you can see there's a lot of viable tumor, very few CD8 positive T cells. Now this is within 7 to 10 days, you give a BRAF inhibitor and you get this dramatic dense infiltration of T cells, and this was performed on, again, the 15 patients with a highly statistically significant result. This is just the box plot in the middle just shows those results. And then we also stained for markers of cytotoxicity, looking at perforin and granzyme B, and saw an upregulation in that. And Wilmot actually preceded our publication showing this very same finding. And so in addition to the T cell infiltrate, we also looked, as Tony alluded to earlier, there appear to be changes within the tumor microenvironment. So we wanted to look in these patient samples at what was happening with immunosuppressive cytokines and also with vascular endothelial growth factor, VEGF. So we looked at IL-6, IL-8, IL-10, and TGF-beta and saw a decrease in IL-6 and IL-8 in the patient samples from pre-treatment to on-treatment. Greg Lazay's group at MD Anderson looked at IL-1 alpha and saw, again, similar findings with a decrease in immunosuppressive cytokines. And then interestingly, Patrick Hu's group at MD Anderson looked at, I believe it was 10 different samples from our patients where they looked at pre-treatment versus on-treatment values for VEGF, saw virtually, a decrease in virtually every patient except this one patient who had de novo resistance. So this is patient 10. She progressed immediately on therapy, and she actually had an increase in expression of VEGF within 2 weeks of treatment. And so, but a finding that was somewhat surprising to us was that the T cells that were actually infiltrating these tumors within 10 to 14 days of therapy actually had high expression levels of TIM3 and PD-1. Probably not too surprising, simply because it's, they can be activation markers. But what was even more profound was that within the tumor microenvironment, we actually saw a pretty dramatic increase in PD-L1 staining. And George Murphy helped us confirm these findings by IHC. So you can see we did it by RT-PCR, but also did immunohistochemistry for PD-L1 staining. And pre-treatment to on-treatment, you see this increase in PD-L1, suggesting that this could be a potential mechanism of resistance in these tumors. And so we generated one final piece of evidence that supports the hypothesis that the immune system plays a role in the response to BRAF inhibitor therapy, and that was basically by looking at tumors of patients who progressed on therapy. And so what our hypothesis was, is that we would see low antigens before treatment, high antigens on treatment. We hypothesized low antigens again at the time of progression or resistance to therapy, and that's exactly what we saw. And so I'll walk you through that. And so basically we looked, our pre-treatment value is what we normalized to, so those values are all 1 over here, but you see when you treat with a BRAF inhibitor again in this patient, we did this on several patients, I'm showing you one of them, you see this increase in antigen expression. No surprise, I'd shown you that before. But what happens at time of resistance or progression is that you actually lose those antigens and they actually go below the baseline. This patient actually progressed on therapy and then went on to BRAF MEK after being on single agent. We were able to restore antigens a little bit, but it was a little too late. He actually died shortly after. But when you look at the T cell infiltrate, again, it pretty much mirrors what we'd expect. We would expect a low T cell infiltrate pre-treatment, higher on treatment, low at time of progression, and that's exactly what we see. So pre-treatment, very low expression of CD8 T cells within the tumor. You treat with a BRAF inhibitor, you get an increase. At time of progression, those T cells are essentially gone. We were able to, again, kind of recruit the T cells, when we treated this patient, but again, it wasn't enough for him at the time. And so based on that additional patient information, we updated our model where BRAF, oncogenic BRAF, causes a downregulation of melanoma antigens, but also causes an increase in the immunosuppressive cytokines and VEGF. And when you block BRAF, see if I can get this to work, there we go, you get increase in antigens, you also get a decrease in immunosuppressive cytokines, and you get recruitment of CD8 positive T cells to the tumor microenvironment. Now, where do we stand with regard to animal models, either supporting or disputing this. So there's several models that have demonstrated improved anti-tumor activity of immunotherapy in the setting of BRAF inhibition. One is Tony's paper. The other paper that he just published, I don't list here, but that's another supporting piece of evidence. Patrick Hu also has published that there's synergy essentially between BRAF-targeted therapy and immunotherapy. Christian Blank's group showed no synergy with anti-CTLA-4. Caveat with this was the inducible BRAF Pten model. So in the primary tumors, they actually saw a decrease in T-cell infiltrate, and they saw no survival advantage when you combine BRAF inhibitors with anti-CTLA-4. I think still an unanswered question. I think we need to test it more. We personally have used the BRAF Pten model in collaboration with Marcus Bosenberg and Martin McMahon. And rather than using the induced primary tumor, we generated a cell line and used subcutaneous tumors that were implanted in the mice, treated them with the BRAF inhibitor, and then also depleted CD8 positive T cells in those mice. And so I'm showing you data that basically shows that when you use a BRAF inhibitor in that model, the CD8 T cells actually play a critical role with an abrogated response when T cells are depleted. So this is the Kaplan-Meier plot on the left. The control chow and isotype antibody is here. Control chow and anti-CD8 is here. Here's BRAF inhibitor alone, but then when you deplete the CD8 T cells, you essentially revert it to control. So the T cells really contribute to the response, at least in this model. And then this just shows, somewhat less pretty, but the tumor growth curves where you can see these are control mice, grow tumors rapidly. If they have control in an isotype, again, very rapidly. If they get just a BRAF inhibitor, there's delayed tumor outgrowth, but if you deplete the CD8 T cells in conjunction with giving that BRAF inhibitor, you essentially, revert it back to the control. And so translational applications underlying the research are real and ongoing. There's currently clinical trials that are underway using BRAF-targeted therapy and interleukin-2. We have that up at Mass General. There's also a cytokine working group trial. Biopsies are critical and important in these trials, and we've started to collect. I think we've accrued 5 patients and have biopsy samples on those, but haven't analyzed them yet. There's also BRAF-targeted therapy and anti-CTLA-4. Tony told you a little bit about the effects of that and some of the toxicities. I'll show you data from one patient, which is pretty provocative, but still, I think timing, and Mike brought up too, timing is everything with regard to these combinations. BRAF-targeted therapy and anti-PD-L1 is now, I believe, open. And then BRAF-targeted therapy and adoptive immunotherapy, 2 centers are running these. Steve Rosenberg has a trial open at the NCI, and then Jeff Weber at Moffitt is also doing this. One thing I will highlight, and no surprise to this audience, but that correlative studies in these trials and in other trials are really critical to gain insight into the mechanism. Just doing the trials without doing tumor biopsies or blood draws isn't really the best way to go, and we really need to be careful about doing careful correlative studies when we do these trials. And then also, I think the murine models are quite instructive, and we really need to keep working with those murine models to guide rational use of vaccines and other strategies, radiation, that potentially could augment anti-tumor immunity. And so this is that patient. So this is, Tony showed you, that hepatotoxicity from the BRAF ipilimumab trial, and this is one of those patients that was on that trial. He had multiple cutaneous metastases, and we were able to do some tumor biopsies along the way while he was being treated on these agents. So before treatment, we did a biopsy of one of his tumors. I'm just going to show you the CD8 T cell infiltrate, and essentially there's very few infiltrating CD8 positive T cells. What happens when you treat with a BRAF inhibitor? Again, no surprise, I've shown you data before on this. There are a lot of melanophages, disclosure, but there are also a lot of infiltrating CD8 positive T cells. Now, here at this point, the next biopsy that we did was about a month into BRAF inhibitor therapy. He had gotten 1 dose of CTLA-4 blockade, but it hadn't really had time to work. And essentially, he had no T cells. So, it's really critical to know what's happening with regard to timing on the BRAF inhibitor, because you can see that, pre-treatment, there's very few T cells. The response with regard to T cell infiltrate appears to be early and transient, and Georgina Long has some data showing this too, because the T cells are essentially gone at about a month. Granted, N of 1 here, but I can tell you, in speaking with Georgina Long, she does have some data which really kind of supports this. Now, you give this ipilimumab, and you give it a little bit of time to work, and those T cells are back, and they persist for a long time. Now, am I just showing you selective biopsies? I can tell you, thank goodness these tumors were big, and so we could actually take part of those tumors and send them over to Arlene Sharp, and she could do flow cytometry and look at the CD8 T reg ratio in these tumors. And so basically, what we were able to show is that when we took these pre-treatment samples, the CD8 T reg ratio was fairly low. When you treat with a BRAF inhibitor, you get a modest bump, in that CD8 T reg ratio. You give, you have about a month into the BRAF inhibitor, and just a couple of days into IPI, it's down again, which kind of supports the IHC from the slide before. But you give that IPI time to work, and boom, you get an increase to over 10 from 2, and then it persists for many months actually in this patient. And so, in conclusion, I hope we've kind of shown, or I hope I've shown you that treatment with the BRAF inhibitor does result in an increase in melanoma antigen expression and also in CD8 T cells in tumors of patients who are with metastatic melanoma. That this is associated with an increase in markers of T cell cytotoxicity and a decrease in immunosuppressive cytokines and VEGF, but also importantly, with an increase in immunomodulatory molecules such as PD-1, TIM-3, most importantly PD-L1, and that these results support the hypothesis that there may be potential synergy, but a lot of important questions remain. And I'll just touch on a few of these. These are really kind of provocative questions more than anything I'll be able to answer today. But is there potential synergy, and is there potential added toxicity? So will we increase durable response rates and also lead to more complete responders? But will it increase toxicity? And I think we're already seeing that, yes, there is an increase in toxicity. I think timing is everything with this, though. So timing and duration, what is the appropriate timing? How long does therapy have to be continued? And then a really important question, especially in the era of BRAF and MEK combinations, is, given the data that MEK inhibitors can, be deleterious to T cell function, can you extrapolate these data to MEK inhibitors or to BRAF and MEK? And then something I'll show you from another patient is, can you use other strategies to augment these responses? And then which is the best model from a mouse model standpoint? And then can this concept be extended to combination of other targeted agents with immunotherapy, not only for melanoma, but for other malignancies? And so one final case I wanted to show you is a case of a patient who was basically presented in May of 2010. He presented with stage 4 melanoma. He had bulky pelvic and inguinal nodes, was noted to have a BRAF mutation. This was just when the phase 1 trials were rolling out. He was enrolled actually on the phase 3 trial of this vemurafenib versus dacarbazine, and luckily he was randomized to vemurafenib. He had his best radiographic response at 60% reduction in tumor size in April of 2011, but at the same time developed brain mets and spinal lesions. He got SRS to his brain lesions and then had a complete response. He developed vitiligo. He was completely asymptomatic. He's off therapy and he refuses further imaging. To this day, he's still a CR. This is just showing some of his imaging. So here you can see in May of 2010, this is just one of his lesions where he had this bulky inguinal lymphadenopathy. He got a BRAF inhibitor, had a PR of 60%, but then developed multiple brain mets for which he got SRS. He developed and then had a complete response in all lesions. And so this is just kind of showing you what happened in this particular patient. We published this as a case report in the New England Journal. where, if you look at the melanoma antigen expression, just looking at Melan A and then CD8 T cell infiltrate, he wasn't kind of our poster child, but he did have an increase in both. So you can see pre-treatment, not a lot of Melan A, very few CD8 T cells. You treat with the BRAF inhibitor, and this was at day 14, he gets an increase in Melan A and gets an increase in CD8 T cell infiltrate. And so what do we think happened in this patient, and how can we learn from this patient? I think, as Roger had said, we kind of need to learn from these individual patients in addition to learning from these large trials. So what we think happened in this patient is that, at the outset, when he had these multiple lesions, he had, a lot of viable tumor cells and very few T cells infiltrating. He was given a BRAF inhibitor, and you get this infiltration of T cells into the tumors. You get apoptosis, a decrease in immunosuppressive cytokines, essentially a more permissive tumor microenvironment. You treat with SRS, and you get localized tumor destruction with antigen release, danger signals, activation of DCs, and then in him you get a regression of all lesions. Will it happen in every patient? Of course not, but I think understanding why it happened in this patient is key. And this is him after treatment. I don't, unfortunately, have a pre-treatment, but he had black hair before he was treated. So. And with that, I'll just, again, thank Dr. Kirkwood and Tony for inviting me to speak, thank the organizers, and thank all of you for your attention. Then all the people who actually did the work, people from Mass General, where I work with my new family at MD Anderson, and then, of course, the patients who were treated on clinical trials. Thank you.